Welcome to the Compassionate Healthcare Supporting Patients, Supporting Caregivers, Mitigating Risk webcast. My name is Christine and I will be the operator for today's call. The slides will advance automatically throughout the presentation. To enlarge the slides, click the Enlarge Slide button located above your presentation window. Should you need technical assistance, click on the Help icon. If your screen freezes or the slides do not appear to be advancing as they should, please try exiting and restarting the session, as it may be an issue with your connectivity. At any time, you can submit a question using the Ask a Question box located on the webcast interface. Please note that this conference is being recorded. I will now turn the call over to Mr. Mark Vanderlinden of CNA. Mark, you may begin.
Thank you, Christine. As Christine noted, I'm Mark Vanderlinden, a risk control consultant with CNA Insurance, and welcome to today's program. Before I introduce today's program, though, let me make a few announcements. As Christine noted, today's program will be recorded and available online for 90 days following the presentation. The program can be accessed at our new website, cna.com. I encourage you to take some time after today's program to visit the new CNA website if you haven't already done so. All attendees will receive a copy of today's PowerPoint presentation and an evaluation after the program. As a reminder, today's program offers 1 hour of American Society for Healthcare Risk Management ASHRM Continuing Education credit. If you wish to receive a certificate of attendance with ASHRM Continuing Education credit, then please send an email to healthproriskcontrol@cna.com. That email address again is healthproriskcontrol@cna.com. Include ASHRM CE in the subject line, please. You also note that any references in today's program to non-CNA websites or products in today's program are provided solely for convenience. And finally, we will be answering questions, but we'll reserve those for the end of the presentation. However, feel free to use the Q&A function on your computer screens at any time during the program to list your question. CNA and the Schwartz Center share the goal of creating healthcare environments that foster compassion, safety, and dignity for all patients and families. Through a collaborative initiative with the Schwartz Center for Compassionate Care, CNA is supporting compassionate care and its importance in improving patient outcomes, reducing medical errors, and professional liability exposures. CNA is demonstrating our support for compassionate care by promoting Schwartz Center membership for both current and prospective hospital and allied healthcare facility insureds through our professional insurance program. I'll have a little more to say about that later in the program. It's now my pleasure to introduce today's speaker. Dr. Beth Lown is a graduate of Tufts University School of Medicine and primary care medicine residency at Boston's Beth Israel Hospital. She's currently an associate professor of medicine at Harvard Medical School and a general internist at Mount Auburn Hospital in Cambridge, Massachusetts. Dr. Lown teaches learners across the spectrum of medical education, is co-directed faculty memberships or fellowships in medical education serving the Harvard Medical School community. Dr. Lown is a fellow of the American Academy of Communication and Healthcare, for which she has served as president and board member. She has served on communication skills task forces, materials development, and standard setting committees and clinical skills for the National Board of Medical Examiners. Dr. Lown collaborates with national and international partners in education and research in healthcare communication and compassion. In 2010, Dr. Lown became the first medical director of the Schwartz Center for Compassionate Healthcare, a nonprofit organization based at Massachusetts General Hospital in Boston. The Schwartz Center is dedicated to strengthening the relationship between patients and clinical caregivers and promoting compassionate health care. Dr. Lown leads the Schwartz Center's National Consensus Project on Compassionate Health Care, a multifaceted initiative to advance compassionate, patient, and family-centered care. She has developed new educational programs to improve providers' compassion and communication with patients and with each other across clinical settings. Her commitment to fostering healthcare professions empathy and compassion and honoring the dignity and uniqueness of those who seek health care has guided her entire career. Please join me in welcoming Dr. Beth Lown.
Well, thank you very, very much, Mark, and good afternoon, everyone. I'd like to thank all my friends at CNA for inviting me to speak with you today. Bruce Mitro, Gozi Naji, Lauren Cutler, and you, Mark. We appreciate the invitation, and I'm looking forward to discussing compassionate health care, supporting patients, supporting caregivers, and mitigating risk. During this hour, I would like to discuss some of the key principles and premises about compassion and compassionate care. I'll share some key strategies that promote such care, and I hope to show you that by promoting these strategies that support compassion and communication in healthcare, we all can play a role in mitigating risk and loss. So let me begin by telling you a story. Some years ago, this previously healthy 40-year-old man fell ill with a persistent cough, low-grade fever, malaise, and weakness. His primary care physician was overbooked. He couldn't see him. So he saw another member of the practice, and he was given a course of antibiotics for what was thought to be an atypical pneumonia. Several visits later, he still wasn't feeling very well. And unable again to see his primary care physician, he was also feeling uncared for. He ultimately went to another institution, and 3 months after the onset of his symptoms, he was diagnosed with non-small cell lung cancer. The year was 1994, and the patient was Ken Schwartz. When Ken arrived for his initial lung biopsies, the nurse who did his screening interview was very harried, she was brusque, until Ken happened to share with her the fact that he had just learned he had advanced lung cancer. The nurse must have noticed the sadness and the fear in his face, and she paused and asked, "How are you doing?" The next day, that nurse came down to look for him. He was waiting on a gurney, waiting to be wheeled into the OR. She sat down, held his hand, and wished him well. Ken wrote about his experiences in an article that was published in the Boston Globe magazine in 1995, and he said about this particular interaction, "This small gesture was powerful. My apprehension gave way to a much-needed moment of calm. I realize that in a high-volume setting, the high-pressure atmosphere tends to stifle a caregiver's inherent compassion and humanity. But the briefest pause in the frenetic pace can bring out the best in a caregiver and do much for a terrified patient." Ken's family and his oncology care team really sustained him through periods of fear and really deep despair. From his physician, of course, he needed clinical expertise, but he also needed compassion and hope. And I don't mean hope for some miraculous cure, but for the certainty that his doctor would provide the best available treatment to extend his life, as long as its quality was acceptable to him. And hope that as long as he was alive, he would have a team of expert physicians and nurses who cared deeply, not just about his clinical condition, but about him as a person. Ken Schwartz died 10 months after his diagnosis of lung cancer, and what mattered most to him was the compassionate care he had received, that in his words, made the unbearable bearable. 2 days before he died, Ken asked his family and his friends to create a center so that compassionate care would not be extinguished in healthcare. So now let me ask each of you, do you think this kind of care is important? If you are thinking to yourself, yes, of course it's important, then ask yourself the question why. Why is this important to patients, to their families, and why is this important to all of us who are providing care? I will respond to my own question by offering you some key principles. And that is, first, that compassion is really the essential foundation of patient-centered and relationship-based care. It emerges from a universal need for human connection and relationships. Compassion is, in fact, correlated with important patient, staff, quality, risk, and organizational outcomes. And importantly, compassion is sustained by organizations that support both patients' and families' experiences with care as well as professional and staff well-being and their experiences of caring. So what is compassionate care? This is our definition. It is all about recognizing, understanding, acknowledging, and responding to ameliorate others' concern, distress, pain, or suffering. So what has to happen in order to be able to offer compassionate care? It sounds so basic. We all should be able to offer compassionate care to others, right? But there are actually many preconditions that have to be in place in order to be able to do so. First of all, caregivers and staff need to be able to notice when someone is concerned or upset. But honestly, today's exam room computers, all the hospital technologies and the alarms, they all divert our attention from the patient's eyes into facial expressions. We're focusing on screens and displays and phones. But if we do notice facial expressions of sadness or pain or the welling up of tears, neural networks in the brain are automatically activated, and we begin to be able to imagine what that other person is feeling. And this happens automatically through the neural networks in our brains, part of the mirror neuron system, other areas in the brain that help us process and understand emotions, and this results in something we call empathic concern. We still need to communicate effectively, though, to understand the nature of that particular patient's context and needs, and we need to be able to communicate with other members of the team so that we can share our information and our collective experience and expertise. Actually today, really everyone could be considered to be a member of the healthcare team, whether you're a patient, a surrogate decision maker, or a professional. We all bring our own special expertise to the table. Patients and families are experts on the patient's needs, their concerns and experiences, and professionals bring their own expertise and, of course, professional judgment as we try to engage in collaborative decision making. That's the ideal state, at least, a vision, really, of compassionate and collaborative care. But we also need support. We need systems that support closed-loop communication and that enable follow-up planning for really everyone who touches the care of the patient. And we need a steadfast commitment to the patient's well-being and needs above all. And research tells us that we need organizations that have compassion for staff and professionals that support the well-being of their professionals and staff. So I asked you a bit earlier whether you thought that compassionate care was important. And we actually asked a nationally representative sample of 800 recently hospitalized patients, 510 physicians, a very similar question, whether they thought that strong relationships, effective communication, and emotional support were important in the successful medical treatment. And in our sample, 85% of patients, 76% of physicians said yes, it was very, very important. It could even make a difference in whether a patient lives or dies. We asked two more questions that I'd like to ask you today, and you can respond yes or no by just clicking on the screen with your mouse. So my first question is, do you think the U.S. healthcare system provides compassionate care? So click away, and we'll see what we get. So far, at least, we're seeing that 66.7% of you all sitting out there would say no to this. The U.S. healthcare system is not providing compassionate care. That's interesting. Okay, here's one more question for you all. Do you think most healthcare professionals provide compassionate care? So click away again. And then let me see what we've got. Aha! Wow. 100% said yes. That's really a vote of confidence. All right, so let me show you what we got in our national sample. Not quite what you guys got. Okay, so in answer to the first question, in our nationally representative sample, we found that 47% of patients and 42% of physicians said that the U.S. healthcare system did not provide compassionate care. And then when we asked whether healthcare professionals provided compassionate care in our sample, again, 46% of patients, but only 22% of physicians said no, that most healthcare professionals are not providing compassionate care. So interesting, not too similar to what you all said, but clearly we have a disconnect between what patients feel they're receiving and what physicians and perhaps you all feel is being provided. So is there any other evidence to suggest that this disconnect actually exists? Let me show you this figures from a really interesting study by Dr. Emile Leschaud and colleagues. This is part of a large multi-institutional study investigating how closely physicians' perceptions match their patients' perceptions of their suffering. So over 6 months, they distributed this survey to all hospitalized and ambulatory patients who came to one of 2 400-bed military teaching and referral centers. And the survey asked the patient and his or her physician to rate the extent of the patient's suffering as they related to 6 different domains. And these were pain, physical non-painful symptoms like nausea, emotional suffering, systems issues like long waits, being unable to afford medications and stuff, and communications issues like my doctor doesn't listen or doesn't take into account my wishes, and also sense of loss. So these little figures in this slide, these are called violin plots. Up the left side are ratings from 1 to 5, and 5 indicates a maximal contribution to overall suffering. And the overall degree of correlation in perceptions between physicians and patients is reflected in how closely the 2 shapes match. So the physician's perceptions are on the left, the patient's perceptions are on the right, and the results showed that only 68 out of 222 responses, that's 30%, showed agreement between physicians and patients' estimates of the extent to which poor communication, emotional factors, loss, and systems issues contributed to the suffering of patients. That is a pretty significant disagreement about the nature and causes of suffering between patients and physicians' perceptions. So what do we know, at least about hospital physicians' compassion, communication, in risk? This is from another study by Henry Stelfox and his colleagues, and they correlated patient satisfaction with physician risk. And they used the surveys that are commonly used, Press Ganey, the Consumer Assessment of Healthcare Providers and Systems, and they grouped physicians into 3 groups, 3 terciles, according to how they scored on the patient satisfaction surveys, and then they correlated that with episodes identified by risk management and lawsuits. And here they found a significant association between satisfaction survey ratings of patients and risk management episodes. But it wasn't just any part of the satisfaction survey. Patient satisfaction with their physician's skill was not associated with risk. But there was a significant association between patients' responses to 4 questions addressing the amount of time the physician spent with the patient, the physician's concern for the patient's questions and worries, how well the physician kept the patient informed, and his or her friendliness and courtesy. And these are all components of compassionate, patient-centered care. So these patient experience and satisfaction surveys, they're very important indicators, but they don't necessarily measure how well teams communicate and collaborate with each other or with the patient and the family. And some of this is really reflected in sentinel events because most of the time that reflects poor team communication. And you can see that the proportion of sentinel events related to poor communication is striking. Really responsible for 65% of sentinel events reported to the Joint Commission, 80% involving related to delay in treatment, and certainly a greater proportion of medication error-related fatalities. So this kind of communication is critically important. Team communication really becomes even more complex as care shifts to ambulatory settings because patients' conditions are managed over longer periods of time across settings, across multiple healthcare professionals and staff. And we know that the absolute number of malpractice claims has been decreasing, but the proportion of claims related to delays, especially delays in diagnosis in ambulatory settings, increased significantly to 43% in 2009. So we saw that patient satisfaction with hospital physicians was significantly associated with risk. The question is, does the same hold true in ambulatory settings? And the answer appears to be yes. This is from a study of patients receiving care from a large multi-specialty physician organization in Massachusetts using similar patient satisfaction survey items that were adapted for outpatient settings. And regardless of physician specialty, the quality, again, the quality of physician-patient interactions and care coordination were inversely associated with patient complaints. We see that over and over again, if you look closely at what drives patients or families to sue physicians, it's really the quality of their interactions and relationships. It's about feelings of being abandoned, not being cared about, devaluing the patient or the family's views, poor information sharing, failing to understand the patient or the family's perspective. These are all compassion failures and communication failures. Conversely, primary care physicians who engage more in dialogue, who elicit their patients' concerns, emotions, opinions, who check to be sure they're actually on the same page, and who encourage patients to participate in conversations, these physicians have fewer malpractice claims. There's another study by a doctor named Ambati and his colleagues, and they actually took audio tapes of surgeon-patient interactions in the office. They muffled the audio tape so they couldn't hear the content, and they just coded the tone of voice. And what they showed here was that surgeons who had gentler, less dominating tones have fewer malpractice claims. So there's something about welcoming conversation, being open, engaging patients or families in dialogue that is both compassionate and improves communication and relationships. So what's the take-home from all of this? Really, it's that patients' experiences of care, especially the quality of their interactions with physicians, also nurses, and in fact, the entire clinical team, they matter, and they correlate with complaints and risk management issues. And the kinds of perceptions that matter include whether patients feel that the people taking care of them have demonstrated concern for their questions and worries. Isn't that all about compassion? Whether they're caring and kind, whether they understand who the patient is as a whole person, not just as a diseased body part, whether they provide clear explanations, whether they follow up and coordinate care, and whether they spend enough time with them. So we know that there are just an awful lot of systemic challenges to providing compassionate care. These are felt acutely by patients and providers and staff alike. There's a heavy workload. Sometimes the staffing isn't sufficient to meet the demands. There are burgeoning administrative and operational requirements. There's discontinuity, fragmentation of care. Sometimes there are conflicting values between providers and organizational leaders. There is, especially amongst physicians, a loss of autonomy and sense of control. And amongst many of the clinicians who no longer come into the hospital, there's a really painful sense of loss of community with colleagues. And then staff input may not be elicited, or if it is, it may not be acted upon. All of these are really difficult, and it makes communication and compassion a lot harder to provide. I also want to point out that we are in the midst of a burnout epidemic amongst healthcare professionals. This is really a problem. First of all, healthcare professionals are not particularly good at caring for ourselves. And then there are those of us who give and give and give and give until we can't do it anymore because we're completely exhausted and depleted, and we haven't recognized the warning signs of burnout. Burnout is really emotional exhaustion, depersonalization, which means treating people like objects, and low sense of self-accomplishment. And the rates of burnout amongst doctors and nurses range from 30 to 60%. One more thing. The statistics on physician-completed suicide are shocking. especially amongst women physicians. They are greater, 130% greater amongst women physicians than the general population. Clinicians, staff, we experience secondary trauma because of prolonged exposure to others' suffering. We may experience moral distress when we cannot do what we think is right for the patient, either because of organizational priorities or professional hierarchy, and there are reports of disrespectful behavior, even abuse. So it's no wonder really that there's an erosion of employee engagement, which makes it difficult to feel compassion and then, of course, to offer it to others. But there are practices and strategies that have the potential for turning this tide around. This article was very interesting by Laura McClellan, Tim Vogus, and their colleagues. They created something they called a compassionate practice scale, and they correlated their scale with, again, the same patient satisfaction surveys. So they asked healthcare team members about the extent to which their hospitals provided recognition to employees for active caring shown to patients and families, recognition for showing compassion and helping one another, compassionate caregiver awards, regular programs that provide counseling or pastoral care support for employees, and support sessions for departments, units dealing with crises, conflict, trauma, and workplace stress. Interesting. And what they showed was that in all regressions, compassionate care practices, the results on this scale remain positively and significantly associated with these hospital CAHPS ratings. Again, that's the consumer health assessment of hospitals and providers and systems, and the likelihood to recommend the hospital even after robustly controlling for all the variables that could influence this assessment. Okay, so let's summarize the evidence so far. First of all, we have a disconnect between what patients and physicians' perceptions are about suffering and about caring. We have seen that compassion support improves patients' experiences and satisfaction with their care, at least as reported by commonly used national surveys. We've seen that patients' responses on these surveys really primarily reflect the quality of their interactions, that is the caring, the concern, the sense of connection, and the communication by physicians and nurses rather than their technical skills. That seems to be a separate issue. And that the lack of these positive responses and satisfaction is correlated with risk and lawsuits. And that the qualities of compassion and communication, relationship support, these can be supported by organizations that reward and recognize compassion and caring, that provide counseling, individual support, as well as opportunities for providers and staff to get together and discuss some of the challenges that are inherent in patient care. So now let me tell you about the Schwartz Center Rounds. I don't know how many of you out there have attended the rounds, but for those of you who have not, these are multidisciplinary forums for care providers, staff, employees to get together to talk about the challenging emotional, social, psychological aspects of taking care of patients and families and the impact of illness on patients and families. The rounds are 1-hour sessions. They're moderated by trained facilitators. And during this safe space, in this place and time, it's okay to talk about your emotions, including those that involve conflict and distress. They're a place where you can actually share your experiences and perspectives and learn about those of your colleagues, and they're a place to offer and to receive support. We have found that sharing experiences in this way deepens mutual understanding, empathy, and it tends to flatten the hierarchy. You're much more likely to reach out or to feel comfortable sharing what you're thinking and feeling with one of your colleagues if you attend the rounds readily and consistently. So a few years ago, we asked our round sites, and we have over 350 round sites now in this country and more actually in the United Kingdom and now in Canada. But a couple of years ago, we asked our round sites in the U.S. to conduct a session on the impact of errors and malpractice on physicians and nurses. 62 of our sites participated, and the attendees discussed events in which they had participated in or observed an error or been subject to a malpractice claim. And participants described really a wide range of emotions, ranging from shock, guilt, fear, and shame, a sense of isolation, a wish to explain to the patient or family. Some described empathy for the patient and family, and finally a wish to to move forward. And participants said a lot of things about these rounds. They were highly impactful, but amongst other things, they said that the rounds evoked memories of other adverse events, the ghosts of patients who had been lost. Some of this all has been described as the second victim phenomenon, but we also heard something that I don't think is talked about as much, and that is the impact of such events on interprofessional relationships and on the entire community. They talked about being trapped in professional hierarchies, unable to speak with each other, caught in the middle. They talked about guilt by association and how terrible that feels. And we saw that this being caught in the middle, being uncomfortable speaking with colleagues, this happened not just in speaking up between nurses and physicians, it happened also between primary care physicians feeling unable to speak up to specialists. They also described something they called the snowball effect, as caregivers would meet with others who were carrying stress emanating from other sources, and so on and so on and so on, building stress and a sense of low morale, really, amongst organizations after this kind of event occurred. So we looked at the impact of the Schwartz Center Rounds a couple of years ago. We evaluated its impact on attendees at 16 different sites across the country, and we reported this in 2010. We saw that there was a positive response amongst attendees, and that after attending the rounds, they reported having greater insight and focus more on the psychosocial and emotional aspects of patient care. They experienced more compassion for patients and families, and they also reported having a greater appreciation of the perspectives of colleagues across disciplines, better interprofessional, interdisciplinary communication, and a stronger sense of teamwork. And the interesting thing was there was a dose-response curve, so that the more rounds people attended, the more strongly positive the response. We also showed that the more frequently one attends the rounds, the less burnout one experiences. So frequent attenders reported feeling more supported, less stressed, and less isolated in their work with patients. Now, we know that there are many other programs that are specifically designed to improve team communication, such as this teamSTEPPS program that's being piloted nationally by the Agency for Healthcare Research and Quality. And this program, as you may know, includes checklists and various team communication tools that are very important. To date, studies have shown that the program improves staff's perceptions and observations of teamwork, but to my knowledge, there have not yet been any convincing studies correlating the program with reduced risk management episodes or correlations with clinical outcomes of patients. It's very, very challenging to do these kinds of studies. And we see all of these programs as complementary to the Schwartz Center Rounds. They approach quality improvement using different strategies, but we're all aiming at the same goal, and that is providing compassionate, safe, patient-centered care. We also know that to really do this, to truly provide compassionate and safe patient family-centered care, we know that change has to happen at each of these nested levels within the systems that we all work in, from the point of care to mini-systems of practice groups and units to healthcare organizations, and finally to the macro systems at the local and national level. But compassion has to remain at the center of these efforts, and this rests in no small part on the well-being of those who are providing the care. We simply cannot provide compassionate care, safe care, patient-centered care if we ourselves are depleted and unsupported. At the Schwartz Center, we have described 7 commitments that we feel will go a long way to making healthcare safer and more compassionate, and these include compassionate leadership, education for compassion, a commitment to value and reward compassionate care, to support clinical caregivers, a commitment to involve, educate, learn from patients and families and their experiences of care, a commitment to build compassion, to literally hardwire it into how we deliver care so that patients' needs are at the center of care, and a commitment to research and measurement of compassion and its impact on patients, families, and those who are providing the care. It turns out that compassion is good medicine. We know that it heals those who are distressed or suffering. It is what patients and families yearn for, and is really what most clinicians, staff, employees yearn to provide. When we experience compassion within ourselves and we offer it to others, neuroscience shows us that the reward centers in the brains are activated. We feel happy. It reminds us why we chose to do this work. It nurtures our well-being and the well-being of those we serve. And compassion creates a sense of meaning. It creates a sense of purpose. It reminds us of our common humanity. So now, just for a minute, I'd like you to imagine that you yourself are no longer sitting in your office. Just imagine for a moment that you're in a Johnny. You're in a hospital, on a gurney, or in a bed, or you're sitting in an exam room somewhere, and you're feeling ill, you're worried, you're feeling vulnerable, and you aren't sure what's happening or what to expect. You see someone who's coming towards you, who's there to take care of you, to provide care. Just for a moment, think to yourselves, what are the qualities that you would long for in that person? Certainly, expertise and skill is amongst your hopes, but wouldn't empathy and compassion be amongst those characteristics you would long for? Really, it's all of our responsibilities to ensure that compassion is never extinguished from healthcare, and that we remain dedicated to a vision of compassionate and safe patient and family-centered care. So I'm going to leave you, for now, with the words of the Dalai Lama: compassion, love, and compassion are necessities, not luxuries. Without them, humanity cannot survive. Thank you.
Well, thank you, Beth. That's a pretty impactful presentation. Those last few slides, I was still thinking very hard on those matters. Yes, kind of hard to get my thoughts together. Yes, very hard to get my thoughts together on that. Well, let's take some time. We have some time for some questions. If you haven't already, please feel free to use the Q&A function on your screens to submit a written question, and I'll be glad to present those to Beth in the next few minutes. We do have a few questions already. First, I see we've got a question regarding the subject matter of rounds. Are the Schwartz rounds only designed for discussion of errors, adverse events, or can they also be used for general sense of frustration in providing quality care?
Yeah, that's a great question. No, the rounds are not just about adverse events. In fact, that was something we asked our sites to do. In general, the rounds can be about anything that's come up in a given organization. So it can be about conflict. I run the rounds in my own hospital, and we have subjects that come up really about anything. Someone who is having a difficult experience, for example, trying to understand or reach some conception of what their goals of care might be, and no one is agreeing. The patient isn't agreeing with the family, and no one's agreeing with the care team, and so that kind of conflict that's so heart-wrenching, that kind of thing can come up and be discussed at rounds. How to compassionately talk about sad or bad news comes up a lot. What happens when one of our own is suffering and we're taking care of a colleague? And sometimes they're about happy things. So, for example, we've had rounds, and we're not the only hospital this has happened in, rounds about a patient who was in the intensive care unit who was actually dying. And the one thing that patient wanted was to see his daughter get married. And this, we had an episode like this, and then I found out it had happened, and there had been rounds on it in other hospitals as well. the patient was stabilized enough to be able to be brought into a room where he could literally be wheeled in, one of those chairs, a Johnny chair, a geriatrics chair, with the ICU nurses holding all of his equipment, holding his daughter's hand, walking down a little aisle to watch his daughter get married. And I have to tell you that rounds like that make an impact on the entire hospital, on the entire organization for weeks. It really completely changes the culture and the happiness tighter amongst the people in the organization. So we use it to understand each other, to support each other, but they are also really wonderful when they celebrate what's wonderful when we're really at our best in providing compassionate care.
Thank you. We have another question. Do you think that the increased attendance to rounds and increased positive results may actually be due to the type of clinicians who have the availability to attend?
Sure. Yeah, absolutely. This is obviously a self-selected sample. It's tough to do these kinds of studies, but actually we are launching into a new evaluation study of the Schwartz Center Rounds, and we are going to compare attendees to non-attendees, so stay tuned. We're just writing up the research protocol for this, and we are going to look at that. But you know what? I think that if you know something about network theory, that values and attitudes can have a ripple effect, so you should never doubt, I don't think, that a small group of people can make a very big change. So I know it's tough to think about changing the system and changing the culture of an organization, but I truly believe it can happen.
Good. That's positive to hear. You noted earlier in the presentation that surgeon tone of voice may impact potential litigation and patient-physician relationship. Are you aware of any cultural differences or language that have been studied alongside that presentation?
That's a great question. Yeah, these are great questions. Thank you all out there. So there are studies about cultural differences, gender differences in communication, and all of that in terms of their impact on communication relationships and patient outcomes. None that I am aware of. In fact, there's very little research about communication and these topics and outcomes such as risk and malpractice suits or claims. I'm not aware of any in that domain. But, clearly problems with language, cultural insensitivity, or difficulties really understanding the belief systems and the explanatory models, how people are actually explaining their illness to themselves within the context of their culture, that's that is a place where significant misunderstanding can occur. You really need to understand from the patient's voice how they're thinking about illness and what their goals are and how they're understanding the care they're receiving. But to my knowledge, there are no studies looking at that specifically in the context of risk.
Okay, thank you. The next question is, on slide 13, there was a diagrams describing the nature and causes of patient suffering and the perceptions, differences of perceptions between physicians and patients.
Yeah.
Do Schwartz rounds have any impact on those perceptions?
That's interesting. We haven't looked at it between patients and physicians, but I can tell you, and again, this is anecdotal because we haven't specifically studied this, but what happens in the rounds is you get a chance to listen to what it's like to be a clinician that you're not. So, for example, I never completely understood really all of the roles and responsibilities and the scope of practice of some of my colleagues until I started going to the rounds. And then you have this kind of aha experience where you start to understand, that's what your life is like. It just never occurred to me. So you really get to live in the sort of vicariously in the life and the shoes and the roles of a colleague if you're listening when you're attending the rounds. So I think amongst the people who attend, which is really hospital staff, professional and other staff, that does happen, and that was part of what we measured in our teamwork scale. We could show, at least amongst attendees, not compared with a control group, but we could show that amongst attendees, they felt they understood the perspectives and the roles. They had an easier time communicating with each other.
Well, good, good. Here's a question. I'm not sure how you might answer this, but it's interesting. Should the discussions in Schwartz Rounds be included in part of the medical record?
Well, that's an interesting question. These are peer review sessions, peer protected sessions, I mean. And so we, as best we can, we really try to ensure confidentiality of the sessions, both for the protection of any patients or families who might be discussed. We de-identify everything. We make sure no one's going to mention anybody by name. And similarly, we actually require that no one brings conversations about things, about their colleagues outside of the context of the rounds as well. I don't think we would put this in the medical record because the idea is that we're trying to create safe space where we can be together and really think out loud, try to generate in a creative, non-judgmental way how to be with each other so we can improve the care of patients. So it's not like a root cause analysis. It's not like an ethics consultation. The rounds aren't designed like that, so I would think that that they're not really appropriate to place in a patient's chart.
Are there any records typically kept with rounds? Any kind of minutes, or is it strictly an okay?
Yeah, it happens in the moment. Our planning committees, there's a very special way that the rounds are conducted. There's a protocol how to get on board and how to organize the rounds and so forth. And so there are internal records that we keep about what the rounds were about, maybe perhaps what kinds of questions we want to ask, but there are no official minutes kept.
Okay. Another question, is there any thought being given to working with aging services organizations?
Aging services organizations for the elderly?
Yeah, such as skilled nursing facilities, assisted living environments.
Right. Yes, we do have rounds in those environments now, and we're spreading those now. We're just beginning a collaboration with a long-term care organization and nursing home, an organization that has several nursing homes across the country. So the answer to that is a most definite yes. We're very much interested in that setting.
Very good. Another question. How does a facility go about selecting and training facilitators that may be best suited to guide clinical rounds? Schwartz Center Rounds, sorry.
Sure, yeah. So the way this works is if there's an interest at a given site, they can contact us at the Schwartz Center, and our program staff will help them get organized. Just let me back up because there's a bigger question here. So I'll tell you a little bit more about the infrastructure of what goes into organizing the rounds. There has to be a physician champion. That's very, very important. And there has to be a facilitator, a Schwartz Center Rounds facilitator. And that person can come from within the organization or can be external. The Schwartz Center has some lists of people who are external facilitators, or we can obtain recommendations and make recommendations for external facilitators. These are usually people with mental health training and background, psychologists, social workers, people who are comfortable facilitating discussions within an organization. So they have to have some comfort level in running these kinds of discussions, and the mental health background is especially helpful. We also have a planning committee. In other words, each site has to have a planning committee, and that has to be interprofessional, cross-disciplinary, and that's the way that the cases are selected that will be discussed for the rounds at any given facility. The planning committee will discuss some possibilities for discussion and decide on what the particular situation or case is going to be that gets discussed. And then there's a panel of maybe 3 people who will share their experiences of the patient or the family that's going to be discussed from different points of view. So there might be a physician, there might be a nurse, there might be a social worker, there might be a chaplain, there might be somebody else talking about the situation at hand. And then there's interactive discussion because the audience is a big part of this conversation. That's a long roundabout answer to how the facilitators are selected, but I just wanted to give you the larger context about the way the Schwartz Center Rounds are organized.
Good. Are there, another question, are there patient satisfaction scores, impacted by Schwartz Center Rounds? And if so, how?
Yeah, I don't think we know that yet. We were just talking about this, but again, the Schwartz Center Rounds new evaluation study that we are planning, one of the metrics we're going to use are those patient experience surveys, patient satisfaction surveys that I was showing to you that correlated with risk. So we are going to be measuring that amongst people who attend and amongst a control sample of people who do not attend the rounds, and we'll take a look at the patient satisfaction scores in those two different groups. I think it's going to be incredibly interesting. So I can't answer you yet, but stay tuned, and maybe in a year and a half or so I'll be able to show some of that data.
We'll be looking forward to that. I have not a question, but a very positive comment I want to share. Yeah. One of our attendees added this. He says, I don't have a question, but I was at Johns Hopkins Cancer Center yesterday waiting on a surgery patient, and the administrative staff went out of their way to be empathetic to the patient's family. I think the movement is moving to extend past the patient to include families.
Absolutely. As well it should. Absolutely. And that's, usually I will use the words patient and family-centered care. I think that that's absolutely critical. We must focus on the families and even on the communities, in which all of our patients, the families, where they come from. We can't really ignore the context of the patient and think about them as sort of in isolation.
Well, I know for any of us that have had family members in the hospital or receiving any type of care, it certainly impacts the whole nuclear unit as well as extended family. So I could certainly see compassion flowing from not just patient care, but into the, kind of relations and perceptions of family members as well.
Absolutely.
So
I think
important.
we sometimes forget, I think, that we spend just a couple of minutes maybe with the patient, and they're spending their whole entire lives in the context of the family and their communities. But somehow I think sometimes we don't always pay attention to that.
True, and I think that also speaks to the communication that we have with patients and families. I know in my own family, being a healthcare trained individual myself, I have a little different understanding than when I would go to an appointment with my father or mother sometimes to assist them, and we'd leave, and it was just to have them repeat back what they'd heard was sometimes very surprising, very surprising. So irregardless of tone of voice, the content was sometimes misconstrued. So many opportunities there.
That's right. I think that's right, Mark. I mean, because if you think about it, I mean, when you're a patient, when I'm a patient, I'll go in, and if you're feeling afraid or you're vulnerable or you're just not feeling well, you're not going to hear what, all the details that are being told to you. So, in fact, a really, good tip is to ask the patient, just so I'm sure I've been clear, what's your sense of what we've been discussing? Because I want to make sure that we're all on the same page and we're all going to be following a similar game plan. So help me understand what you understand. That is really important.
Do the Schwartz Rounds address that whole health literacy topic? I mean, it seems so big. I know we've discussed it for quite a few years now, but is that part of the rounds as well?
That can be a topic for the rounds, indeed, and it's funny you should mention that because health literacy, of course, encompasses a lot of different things. It's not just being able to read or numeracy, being able to understand and manipulate numbers. It's about being able to interpret, synthesize, and apply what you know. But there's also problems with language and interpreters and cross-cultural interpretation and understanding. So health literacy has a pretty big meaning, but that's a very common topic for the rounds. In fact, we are actually doing our next Schwartz Center Rounds on that very topic. And we have several. This time we chose to have, rather than one patient situation or family situation being discussed, we decided to have our 3 members of our interpreter service just tell their own stories about what had transpired that really impacted care. And it's just fascinating to hear their stories, really, about how sometimes just one misunderstanding of a single word can have absolutely dire consequences for the patient or the family. So, so it's not just about reading, it's about the whole comprehension, interpretation of language and of the meaning of language and of health and of illness that's important in that concept.
Well, we certainly have work ahead.
Yeah, we do.
We do.
It's the good work, right? It's all good work.
It's all good work.
Yeah.
Well, thank you so much, Dr. Lown, for your time today and a very informative presentation. I know we've all benefited from that.
My pleasure, and we welcome any comments. Thank you so much for inviting me.
Well, thank you. As mentioned earlier, CNA is demonstrating our support of compassionate care by promoting the Schwartz Center membership for both current and prospective hospital and allied health care facilities insured through our professional liability insurance program. If you are interested in learning more about this initiative with the Schwartz Center, please call CNA at 888-600-4776. That number again, 888-600-4776, or contact your local agent or underwriter. As a reminder, if you wish to receive a certificate of attendance today with ASHRM continuing education credit, then please email healthproriskcontrol@cna.com. Include ASHRM CE in the subject line. And finally, you will be receiving a copy of today's slides and an evaluation after the program. Please remember to complete the evaluation when received, as it will help us improve future programs. With that, I would like to thank you for your attendance, and this ends today's program.